Hello and namaste everyone. So today we are going to talk about a case study of a papillary breast neoplasm in an elderly woman. So generally, the papillary tumors are most common in a elderly female and presents around the after menopause and in the age group of 60 to 70 years. So they are rare, not quite common as intraductal carcinoma or invasive ductal carcinoma. See, it hovers around 0.5 to 2% of total diagnosed breast cancer, and as I told, they are in the elderly age groups. Why its diagnosis is very important because their prognosis is quite favorable. So, if we diagnose correctly in advance, the patient's the prognosis of patient becomes quite good. But it is very important to differentiate between the benign intraductal papilloma and papillary carcinoma because there are some certain points, certain characteristics like the presence of myoepithelial cells and invasion, the invasive front, the presence of fronds, absence or presence of fibrous capsule. That are the features which defines if it is a intraductal papilloma or it is a papillary carcinoma with invasion. There are also some types of papillary carcinoma like solid papillary carcinoma, intraductal papillary carcinoma, encapsulated papillary carcinomas. The solid part has a fibrovascular course and encapsulated part also has a fibrovascular course. And we need to differentiate those for the prognosis of the patient. So my case was a 70-year-old female has a 6 month of history and presented with this particular mass, which was a firm, fixed and non-tender. And upon the ultrasound guided FNSC was performed, and there was the presence of cystic space which was filled with hemorrhagic material. And after aspiration, it showed the cystic background with foamy and hemocytic-laden macrophages as well as cellular epithelial clusters with cellular columnar cell morphology. The micropapillary clusters were lacking discernible fibrovascular pores, but the proteinaceous background with foamy hemocytic macrophages, which was consistent with cystic uh, morphology. There were tight cohesive spheres and club-shaped fragments with smooth community borders. That shows the encapsulated or solid papillary carcinoma, which has fronds, smooth fronds. And there are some scattered isolated tall columnar epithelial cells were also identified. So all of this made uh, quite quite a good picture for papillary tumor of the breast. Also, there was a paucity of myoepithelial cells. So it was very challenging to differentiate whether this is going to be a papillary benign papillary neoplasm, beta-ductal papilloma, or it is a carcinoma. So as I described the cystic background, the lack of myoepithelial cells, columnar cell morphology, and a highly cellular spherical cluster, it made a quite a good point for the papillary cell neoplasm, papillary tumor of the breast. So anytime we encounter such picture, it is always necessary to make the confirmed diagnosis with core needle biopsy or the excision biopsy because the differentiation between intraductal papilloma and the carcinoma is very important for the prognosis and treatment protocol of patient because the papilloma, intraductal papilloma is just a simple excision of the lump or lumpectomy. But if there is a presence of any invasive front is present or there is a solid papillary carcinoma with some invasion is present. So the PT staging, T staging of the tumor is measured upon the component of invasive part. So if the invasive part is large, it upstages the PT. And if the tumor is in situ, there is a suppose encapsulated papillary carcinoma, and it is entirely inside the cyst in the fibrous capsule. So it becomes the in situ. So PT staging becomes the PTIS. So the management completely changes. So anytime we encounter the papillary picture on the suppose FNAC or then we need to strongly evaluate the tumor for its proper diagnosis and its extent. As I said, there are the subtypes of the papillary carcinoma from solid papillary carcinoma and the invasive papillary carcinoma. Generally presents with palpable mass with bloody or serous nipple discharge. These are the common genes on the mammography and ultrasound. Generally, it shows the asymmetric densities and cystic or hemorrhagic component is very common. The hallmark diagnosis is always the histopathology with IHC and to distinguish between the fibrovascular pores and the myoepithelial cells, the IHC is must. As I said, the elderly patient with invasive breast carcinoma and non-specific type is most common, but the papillary tumors should be diagnosed properly because they carry better prognosis. And if the patient treated better, the patient can live better life with less difficulties. So historical standard, that is surgical excision with modern approach like which include the de-escalation or neoadjuvant chemotherapy based on the presence of the invasive component. Suppose in a solid papillary carcinoma with invasion or encapsulated papillary carcinoma with invasion, there are parts that there are papillary carcinoma is encapsulated inside the fibrous capsule and also presence of invasive part, that is maybe mucinous carcinoma is most common or non-specific type of invasive ductal carcinoma is present in there. So both of them can be combined and whichever part is larger based on this, the PT staging is made and then the treatment protocol and neoadjuvant therapy is decided. So all of this is designed according help to help the patient properly. So it starts with the diagnosing properly. So to identify papillary tumor and to properly guide patient for the next step is very important. Thank you so much. Just out here.